So,
thank you.
I will give this evening a talk on how to improve our clinical practice using sepsis biomarkers. This is my conflict of interest disclosure for this presentation, and as a matter of fact, I would like to start my presentation with a case which is very common, of a male patient of 70, admitted at the emergency department. The reason of being admitted there, actually this is a male patient with a medical history of chronic obstructive pulmonary disease, is because he has fever already 48 hours. His physical examination is unremarkable. His laboratory results, the routine ones, are normal, but you see a chest X-ray with a lot of question marks pertaining to consolidations on the right lung. And the questions you have to answer are, what will you do for this patient? Will you discharge him home? Will you do watchful waiting? Say, for instance, stay another 12 or 24 hours with us, and according to how this is progressing, we will decide what we will do. Start a pertinent erythromycin for 7 days, or any of the above. All of a sudden, you have no more just the routine laboratory labs. You have results on 2 major biomarkers, perception and procalcitonin. And for each of them, you may have a completely different scenario. The first scenario is that the patient has procalcitonin of 0.29 and perception of 500. And then you are dealing with 3 main questions. Give him clarithromycin and discharge him home. Give IV meropenem and admit him at hospital. All this is outrageous. Second scenario. Procalcitonin is 0.30 and perception is 70. Again, same questions. Third scenario. Procalcitonin is 0.15, perception is 500. Again, same questions. In other terms, the first question is, the one biomarker, procalcitonin, telling us that there is need of start antibiotics, but perception is telling us that it's not just an infection. The patient has sepsis. So the answer is 2. Yellow scenario tells us that there is infection, but there is no risk of that the patient has sepsis right now. So the answer is 1. And third is that the patient is severe, but probably this is not just coming from an infection. You need hospital admission and probably IV meropenem. But in any case, you need to be extremely careful. Let's see what all these are about. Of course, I assume that all of us who are watching this evening, they're aware of this seminal publication of February 2020 in Lancet. And why is this so important? Because it is the first time in medicine where Harglobe used the same definition and classification system for sepsis 3 criteria, to answer to the question, how many new cases of sepsis we had in 1 year, 2017, in the world? And the answer is, oh my God, almost 50 million. And 11 million deaths in 1 year. Many, many more deaths than all the deaths which has arrived so far from the new pandemic. So in other terms, we are dealing with a silent pandemic. A pandemic which becomes more and more often, and a pandemic that probably it's not in the web, it's not in the internet, it's not part of our Twitter habits and Facebook habits, but when COVID-19 goes down, this is the most difficult task that we have to do. And why is it so important? After years that we are listening to sepsis, that we are dealing on how to treat our patient, in the very end, what is the only strategy so far that can save a human life? This is the seminal publication of Kumar coming from Canada. It appeared in January 2006 in Critical Care Medicine, and there's a clear-cut key message. If you start antibiotics the first 1 hour, then survival is 79.1%. But for every hour of delay to start antibiotics, I did not say prescribe antibiotics. I said start antibiotics. The time that the antibiotic finds its way to the intravenous cannulae of the patient. For every hour of delay, you need 0.6%. So you need to recognize extremely early, and early means if you wish to save your patient, don't wait that he has symptoms. Use the biomarker in order for you not to wait. However, the other angle of the problem. But as the time goes on, more and more people will die in the ICUs because of infections by multi-drug resistant bacteria. And how bacteria become multi-drug resistant? Because we are responsible for this, of overprescription of antibiotics. Imagine that this is the cat mucosa, and on top of the mucosa you see what this red bricks, which is nothing more than the normal flora. And all of a sudden, a patient is getting antibiotics. And antibiotics, they are very clever drugs, but they cannot tell which are the bacteria that are infecting to kill them, and which are the bacteria of normal flora. They kill both, and all of a sudden, normal flora is vanished. But exactly because normal flora is consisting of billions of bacteria, some of them survive, and they see the ecological gap. They start to replicate, and then flora is changing to resistant. However, someone may say, give us a proof of this. And there is proof. There is a randomized clinical trial, but those who were enrolled in this trial, they were not patients, they were healthy volunteers, and they were randomized into treatment with oral clarithromycin, a macrolide antibiotic, 2 times daily for 7 days, or oral azithromycin, 1 times daily for 3 days. And of course, these patients were getting placebo either for 7 days or for 3 days. And the investigators, over the follow-up of these healthy volunteers, they were getting samples of the oropharynx in order to start for the high-level emergence of respiratory or resistant flora. And look, impressive. On day 8, that means after the stop of antibiotics, okay, there is resistance. They're done with that. But on day 14, resistance persists. And on day 28, we have exactly the same thing. And even on day 42, and even on day 100. So, yes, we need to give antibiotics, but we need to be very careful who is the patient who's in need of it. Let's see what is taking place in sepsis. There is a key cell which is delivering the cytokine storm leading the patient to sepsis. And it's either blood monocyte or tissue macrophage. The cell is under attack of either gram-negative bacteria or gram-positive cocci. Gram-negative bacteria, as they replicate, they release the endotoxin from the cell wall, and gram-positive cocci, they release part of their peptidoglycan from their cell wall. The endotoxin binds to TLR4, peptidoglycan on TLR2. Even bacterial DNA binds to TLR9, and all of a sudden, a whole series of intracellular reactions takes place, which leads to the activation of NF-kappa beta, and this triggers the gene expression of pro-inflammatory cytokines, and these pro-inflammatory cytokines, they induce neutrophilia, coagulopathy, vasodilation, and organ dysfunction. So, we need to handle that. How we handle that? If you search what is taking place on the cell membrane, you will see that between the toll-like receptors, there are some proteins which are called the molecule CD14. This CD14 becomes soluble in order to bind to LPS, to bind to the peptoglycan, and in order to stop them to continue this hyperinflammatory, the triggering of this hyperinflammatory reaction. The soluble counterpart of CD14 is measured and is a biomarker, which is called perception. How perception is increased? Let's inject to humans, to 10 healthy volunteers, endotoxin, 2 different doses of endotoxin. And after the injection, let's measure serially circulating inflammatory mediators, and let's see what is the area under the curve. In other terms, what is the burden, or which is this mediator which is produced the most. And you may see, and I would like to draw to your attention to the fact that the y-axis in this scale is logarithmic. And what you see on top left, that receptor is produced in much greater concentrations than C-reactive protein, or interleukin 10, interleukin 1 beta, interleukin 6, IL-8, or TNF-alpha. So perception is really the biomarker that we need in order to get the information that there is a stimulation similar to what I presented to you in the previous cartoon. Indeed, perception has been measured in several prospective trials in patients with signs of infection. And the question is whether there is a concentration, a cutoff of measurable perception, which can tell if a patient has sepsis or not. You see that some of the studies, they use the old sepsis 1 definition, others the sepsis 2 definition, the most recent ones, the sepsis 3 definition. But in all cases, the meta-analysis of the studies ends up that the sensitivity of perception for the diagnosis of sepsis is close to 90%, and the specificity is around 75%. We do not have any other biomarker which can deliver a sensitivity of 90% for the diagnosis of sepsis. Allow me to show you some data coming from my group, because the question is not just if perception is greater in sepsis than in non-sepsis. The question, and this is the information that you want to have this evening, is what is the exact concentration of perception if a patient has that can tell you this is the patient who has sepsis. So we used originally a derivation code. 183 patients. From them, 173 were analyzed and were excluded. 111 had sepsis, 62 did not have sepsis, and we elaborated a diagnostic cutoff of 350 picogram per ml. We wanted to be certain that this is indeed the cutoff we are looking for. So we were in need of 2 validation cohorts. The one were 55 patients who were admitted in the emergency department, and the second, 115 patients with COVID-19. The first question: what is the sensitivity, the specificity, the positive, and the negative predictive value among all these 3 cohorts of the cutoff of 350 picogram per ml of perception for the diagnosis of sepsis? You see that this average 90% of sensitivity is fully reproduced, but also look at the negative predictive value, which is also of this level. Second question: we want for perception to predict mortality. Oh, there we have something important. Sensitivity for death after 20 days is 90%, but negative predictive value is almost 100%. And somebody may tell me, negative predictive value? Why is this so important? Negative predictive value is telling If a finding is negative, what are the chances that you don't die? In other terms, if the finding is negative, that you can discharge safely your patient home, and indeed, your chances to do that by using perception is much more than 95%. That someone may tell, oh, the findings are due to comorbidities. And so, in order to be certain that the findings are correct, we want a logistic regression multivariate analysis, where we see whether for the diagnosis of sepsis, even if a patient has a lot of comorbidities, particularly diabetes, particularly COPD, if perception is an independent variable showing who's the patient who has sepsis. And the answer is indeed, perception more than 350 is the most strong measure associated with sepsis. And if you do that for 20-day mortality, you get exactly the same result. Well, someone may say, oh, this is just one study. Or it may have the cohorts, it's coming from just one place. What meta-analysis of other studies looking on severity are giving us? So we need this meta-analysis, 15 studies, different healthcare settings, different countries. And the answer is, given the cutoff of perception to predict risk of death, it's the same. 350 picograms per ml of studies having to do with severity of COVID-19 between 2020 and 2021. However, very important, pre-sepsis is a proper type. You need to interpret differently when you have a patient with renal dysfunction. These are recent results of a prospective study in 837 patients. They confirm that this cutoff, they suggest for a cutoff of 500, but even the cutoff of 350, where most of the studies are warning about, used if the patient has a normal renal function. But if the patient has an eGFR less than 60, then your cutoff should be 1,000. Other biomarker. In the case study with which I started my talk this evening, I used perception, but also I used procalcitonin. And procalcitonin is a prohormone or a propeptide, which, however, in sepsis, is not produced just from the thyroid gland. The procalcitonin, which is measured, is produced in tiny amounts by your tissues and lung, liver, kidney, adrenals, thyroid, white blood cells. They contribute tiny amounts, and all of them give the average which is taking place in the body and which is measured. What are we in need of for procalcitonin? We need to incorporate this in an algorithm which tells us if we need to start antibiotics. In case when we start antibiotic, which is the correct time to stop antibiotics, and this algorithm needs to be adapted according to underlying severity, settings, and comorbidities. But we can trust such an algorithm, provided that the use of this algorithm does not introduce harm, provides clinical efficacy, and most important, is validated through randomized clinical trials. So, first question, can procalcitonin tell us when to start antibiotics? Look at the suggested algorithm tested in randomized clinical trials. First and most important, before you measure procalcitonin, you need to trust medical history and physical examination. Procalcitonin follows. But if procalcitonin is less than 0.10, there is no need to start antibiotics. If it's between 0.1 and 0.25, this is not suggested. If it is between 0.25 and 0.5, it's encouraged. More than 0.5, it's mandatory. First randomized clinical trial, published almost 20 years ago in Lancet. 110 patients, they get standard of care. What does that mean? Start of antibiotics according to the judgment of the physicians, but 112 start antibiotics using this algorithm. And you see that even if this final diagnosis is community acquired or exacerbation of chronic obstructive pulmonary disease or bronchitis, the use of procalcitonin decreases dramatically the consumption of antibiotics. And someone may say, was there any difference in mortality between the two arms? I tell you, by definition, no. So, you save antibiotics and you do not harm. Several times, one study is no study, so this has been repeated another 3 times. Always same result. Decrease of consumption of antibiotics, no harm of the patient, no effect on mortality. But you start with antibiotics. Shall we stop it? But the patient is getting better. Always, after 3 days or 4 days, when the patient is getting better, our eternal problem is, if I stop antibiotics and he gets undertreated, and if the patient relapses, so use a biomarker to tell us that the reaction of the hospital treatment is the desired one. Inflammation has stopped, and you may safely stop antibiotics. So you need to apply a stopping rule of antibiotics based on procalcitonin. What does this mean? You decide to treat the patient with antibiotics. Before start of treatment, you measure procalcitonin. Then you start treatment of antibiotics. And you measure procalcitonin after 2 or 3 days and after 5 to 6 days. And then you use specific change of procalcitonin, and you decide based on this change that now is the time to stop antibiotics. So the question comes, which are these criteria, and whether these criteria have been validated through randomized clinical trials. We have 2 randomized clinical trials where the stopping rule that was used was that we anticipate a more than 90% decrease of baseline procalcitonin, or we stop antibiotics when procalcitonin is found below 0.1. 3 randomized clinical trials where the tested decrease was more than 80% or less than 0.5, and 2 when that was more than 9% and less than 0.5. Look at all these trials. 7 randomized clinical trials. All of them, they give the same result. The use of this algorithm affects a decrease of the days on antibiotic treatment, and there is no risk for the patient. But allow me to show you how you can also save the gut microflora and indeed save the patient through this approach. This is a randomized clinical trial which was published by my group at the Blue Journal in January 2021, and actually we enrolled patients with sepsis. The majority was sepsis from community-acquired pneumonia or sepsis from acute pulmonary disease. Patients were randomized in 2 groups. The first group, the physicians, they could administer antibiotics as long as they were wished. Second group, procalcitonin is measured at baseline, and on day 5, we measure again procalcitonin. If it is decreased by 80%, or if we find that less than 0.5 nanogram per ml, we stop antibiotics. And if this is not the case on day 5, We repeat after 1 day, after 2 days, after 3 days, and we stop antibiotics when this change is found. We watch the patient when we follow up until day 28 and also for 16 months. Meanwhile, we collect samples from stool. The primary endpoint was if, through this approach, we could decrease what we call the adverse events of an infection. In other terms, if a patient could get any of infection by the drug-resistant bacteria, or infection by Clostridium difficile, or death, which is due to baseline infection by both drug-resistant bacteria or Clostridium difficile. So this is the primary study endpoint of what we call the progress trial, which is indeed unique. If you stop early antibiotics using procalcitone, you see that this dreadful incidence of events for 180 days out of treatment, infections by drug-resistant bacteria go down, infection by Clostridium difficile go down, death is going down. So the relative protection of the patient is 55%, and of course statistically significant. And someone will say, why? So, as I showed you in the design of the trial, we screened and we followed the stool patients for colonization by Clostridium difficile and multidrug-resistant bacteria. And the question was, what is the chances that you develop this infection-associated adverse events over follow-up if you become colonized? And you see that the odds of having that by day 7, if you are in the standard of care arm, is more than 10. And it goes significantly down to almost 1 if you stop antibiotics by procalcitonin, and this is exactly repeated on day 28. So, in other terms, we have a mechanism. You use the early stop of antibiotics, you decrease colonization of the stool by both the drug-resistant bacteria, and you save your patient. And indeed, you save your patient. You see all of a sudden that 28-day mortality was 28.2% in the standard of care group, and 15.2% in the procalcitonin guidance group. And this is an overall relative 49% decrease of the hazard of death. And how also can this be achieved? Okay, we showed already. You have a decrease of infections by drug resistant. You have a decrease of infections by Clostridium difficile. Indeed, exposure to antibiotics, as you may see, was lower, but antibiotics that have adverse events. Which are these adverse events? It's diarrhea. It's acute kidney injury. It's electrolyte derangements, elevated liver function tests, arrhythmias. And all these goes down if you give antibiotics for a shorter time period. So, I would like to close my talk for this evening by delivering some key conclusions. You see that I presented 2 different biomarkers, and they provide different clinical impact on the patient. They are fully complementary. You use perception to evaluate the patient. No doubt, better kinetics than C-reactive protein and soluble cytokines. A concentration more than 350 picogram per ml is diagnostic of sepsis and risk for death by severe infection, and leads you to consider immediate start of antibiotics. However, low concentration has an extremely negative predictive value, which encourages you to consider discharge from the emergency. Calcitonin is used to guide the stop of antibiotics because it's decreasing infection-associated adverse events after 188. It decreases mortality and antibiotic-associated adverse events through decrease of stool colonization by multi-drug-resistant bacteria. And the rule is that you need to monitor a decrease by at least 80% from baseline. This is the time point that you select to stop antibiotics, or when you find calcitonin to be below 0.5 nanogram per ml. Thank you very much for your attention, and I'm happy to get any questions.